I've known Dr. Block for about 20 years now, and he's a national expert in amputation and prevention of amputation in peripheral arterial disease. So his lecture will speak for itself.
Perfect.
Alan.
Perfect. Thank you. Okay. Are we up on? So anyway, we're going to talk about recognizing vascular disease today. And I'm a podiatrist, by the way, and I want to tell you the best compliment I ever got. About 3 weeks ago in Washington, D.C., I was doing a talk for dermatology and podiatry. It was a really big meeting, about 1,000 doctors. I got off the stage and I went over, and these are colleagues I kind of know. They said, "We didn't realize you were a vascular surgeon." They honestly thought I was a vascular surgeon, so by the end of the weekend, I was Dr. Block, the vascular surgeon. I don't do any of this. I don't do the saving like this. But I want to tell you what has happened is the collaboration with vascular medicine, with the interventional radiologists and cardiologists and vascular surgeons have changed the way, the dynamic of what I've been able to do. It's made my practice busier in a good and a bad way because these patients need a lot of attention. So I'm just going to take you through how I think, okay? So the first thing to talk about, and we've mentioned it all day, is diabetes. And I just listened to a lecture by Lee Rogers, and it was really good. And he said 80% of what you tell a patient, they forget on the way to the car. And it's true, because I can say, I do a thing, I'll say, "I'll see you in a week, Mrs. Jones," and I tell her 3 more times. At the very end, as I'm walking out, "I'll be seeing you in a week," and 2 seconds later, my office manager's at the door, "When do you want to see Mrs. Jones back?" She forgets. So you know she doesn't remember what I told her, right? She doesn't remember that. And that's exemplified with diabetes, because if you're not getting glucose to the brain, and you heard our sleep doctor, Dr. Raphael, say you need more glucose to dream, right? I think these people are in a dream state, and they're burning, they don't get glucose, right? It's flowing around the outside, but not getting where it needs to be, and they don't understand. We're speaking English, they're hearing Spanish, right? That's what they're doing. So you have to realize these people don't get a lot, and I can't write everything down. I can't do that. But you have to realize what's going on with these individuals. Now, the cost of treating these diabetics is incredible, because number one reason a diabetic is hospitalized is for diabetic foot infection. 80% of patients who are hospitalized with diabetes are for foot infections, right? So I'm going to kind of go a different avenue here and not just talk about peripheral arterial disease. The biggest thing in my practice is no longer peripheral arterial disease, it's infection. And why would intervention and infection go together? Because if you can get blood flow to the area, the body's immune system can help take over, and it can help fight the infection, right? So we've established that, and I can get the medicine down to the patient's wound in the first place. And you can see here how expensive it is to treat a diabetic foot infection. It costs more than 5 of the most costly forms of cancer. If you take a look at, I'm going to start out by showing you a case that I'm working presently on and have been for the last year and a half. 3 years ago, this gentleman, 47-year-old, he has an A1C of about 8. He has a job as an engineer. He's a smart guy. He lives 3 hours away from me, okay? And usually when you drive 3 hours to see me, it means it's pretty serious. And this is what it's showing. Now, this is 18 months, but 18 months earlier, he sprained his ankle, stepped in a hole, twisted his ankle, went to the hospital. They took x-rays. It was negative for fracture, okay? But this, very simply, is a good foot at 18 months ago. Right? Now, he's had a previous ankle fracture, and this is the foot as we go along. This is in a year's time. The foot is collapsing, as you can see, taking a look. This is just falling. This is called Charcot disease. He didn't break it, but he did something worse. He started a neurogenic response, which we still don't understand how it happens, and the foot simply just starts breaking on itself. So every time you step down, the bones give way, okay? And that's really what we're looking at, and it took a year to progress to this point. But here's the amazing part. You know, you come in and they have the infection like this. We know that, right? And so the first thing is, how does a diabetic not get this treated until it gets to this stage, right? Because now it's got gas, and now we're worried about taking it off at the knee. They can't feel it, right? And most of the time they can't smell it for some reason, and maybe they can't see it because the same problem they have with diabetes is they lose their senses. And so what we do is we open it up, we drain it, just kind of like we saw earlier, right? Just like what you did this earlier, right? Same kind of thing. The first thing is decompress it, right? So that's our first thing. And now I want to know if he has circulation, because he's not bleeding great for what I did to him here. But this is going back to that guy. Now, he comes to me, and I'll show you the side in just a second. You'll notice here, not looking too bad when you look this way, but this is his foot when he comes to see me at 13 months. Now, he has a podiatrist, he has an orthopedist, he has a hospitalist, he has a family doctor, internal medicine. And the reason he came to see me, an infectious disease doctor who now is treating the osteomyelitis because the bone is now infected, said, I got a guy up in Columbus that I think will see you. Call him, or you're not going to have a leg. Because every one of those specialists kept saying, not looking bad, looking better. I'm going to show you this. This is how he shows up in my office. Okay? So 13 months later, they're going, yeah, it's healing. Looks good, right? We affectionately call this the baboons behind, right? But this is what he's got. That's his ankle sticking out the side of his leg, an infection. In my office, I immediately do a bone biopsy. They're numb, so I do the bone biopsy right there, because why cost the patient 10 grand to do something I can do in my office? And I send it out for DNA testing. So I don't do auger plates, I don't do culture and sensitivity, I do DNA culture and sensitivity, which is big, because in less than 7 hours from the time they get it, I know what he has, and instead of giving him Zosyn and vancomycin or whatever else, I can now start treating this patient. Now, I'm angry because I don't understand how he got to this point, right? And so there's his ankle sticking out of the side of his foot on the other x-ray. And very, very simply, that's that DNA test I was talking. Anything that lights up on that column there, if you take a look, it means he has it. And, of course, he has MRSA. And this is just, once you get to that stage, the next thing I want to know what derivatives of that bacteria he has that I can't treat him, because I want to keep him on oral antibiotics if I can. So there's two things that go along with that. And the first thing is he has to have circulation. So I say, we're going to take you to surgery. He goes, oh, they were talking about that. I go, no. We need to take you. And he goes, oh, my wife needs her knee replaced. I want to wait until that's done. So 5 months go by. And here he is. The infection's under control. You can see he's healed the baboon's butt. But you see the worst part now? Now I know he has, if you take a look here, if you take a look at him, you can see that's necrosis. And that scares me more than anything else, because he's not just going to lose a toe. He's going to lose a lot more than that. So I say, Mr. Rice, we're going to take you to surgery now, right? His wife's doing better. He's ready. This is what it looks like. And I've never seen anything like this in my 30 years. So when you take a look at that, that is unbelievable. And this takes heroic surgery to have done. So he's been intervened. We've got the infection gone. I've injected his bone with antibiotics, and I use calcium phosphate, which is a flowable thing. So I inject the antibiotic straight into the bone. So if the circulation is not getting there, the bone will, right? And you can see here, and we're just going to cut through this, because now you can see here how deep that goes. So that's after I've cleaned everything out. And it's just full of dead tissue. It's just nothing healthy. And the necrosis is getting better. And of course, once I put him in the frame to get his foot is so beaten up that I have to get it to even, after almost 2 years, his foot has shortened. And in order to get him back to length so he can walk, I have to put him in this frame so I can slowly bring the soft tissues. Because if you bring it out, he's going to go into shock, right? He's going to have vascular shock. He's going to go to vasoconstriction, and his nerves are going to stop working at the same time. So you can see all the work we're doing, and this is a $40,000 external fixator, we call it a cage, that we're putting him in, right, type deal. And you can see once we get that done, the next move is to nail everything. So I got everything back where I think it should be. His foot looks pretty good, right? And I put this in, and we're all shaking hands because we did it at the university, and we're like, and this has taken a lot of time, okay? This has taken probably from beginning to end, it's probably been about 8-9 months. So he's into this almost 2.5 years, a little over. And everything's going great. Tuesday night, I'm sitting home one night, and this picture comes. He sends me a picture of this. So the infection's back, okay? The infection's back. Now, I put that external fixator on for $40,000. The rep, they have a really, really complicated thing that tells you how to move these little bolts so we can change the direction of his foot so I can get it where I want. So when I decide to fixate it, I can, right? The rep let him sit for a month, never sent the program, never did it, right? I didn't know it because the patient was 3 hours away from me, and I just assumed, and you know the problem is, the minute you take your finger off that button, you've lost it. And we'll talk about that, right? So this guy sat for a month with a cage on, and so he was with it for another month. Now this is infection. The infection's still there. That's the only thing that will spit a screw out, because that's mounted into a beam, and it shot it out. But more importantly, you see necrosis on the back of his heel from him laying around. The heel is the hardest thing to heal because it has no dedicated blood supply. It's all done by tributary. So if you already have a posterior tib, an anterior tib, and a perineal that are already having problems, this is not a good sign, okay? So, of course, I bring him in. I take the screw out, do some other fun things to him. This is what I'm left with. Now, you can see he's starting to heal over here. You can see the redness is going away. And in the interim, it turns out that we sent him back for durability to see how he was doing. And it turns out that he had clotted off what they had opened up, and he went through a second intervention, which is really important here because that's key, right? I checked it. It wasn't flowing. They went back in. And they don't question it anymore. They know what we're doing. We got a great team going on. I'm putting on this external fixator, and the nurse who's leaving me that day to go up to the cath lab to become a cath nurse says to me, "Why don't we save this guy a lot of headache and just cut his leg off now?" That is the worst dagger you can ever do to me. Because I've centered my life saying, if you drive 3 hours and you ask me to help you, I heard a lecture last week, and I know Vince's last name, and he said, it's about the patient. It's not about you. It's not about the nurses. It's not about the hospital. It's about the patient. And I have to tell you, the worst day of my life is the day I go in and I do that lecture where I say to the patient, you're losing your leg. It's a horrible thing because that's the first time that it sets in. And I have to tell you something. We take walking and movement for granted. We do. And you'll see how many people move after they have this done. So anyway, this is him healing, right? Just so you know, he's doing great, except he breaks down the middle of his foot now, which happens. Right, if you look here, it's infected because he has just inane infection. I go back and I put him in a cast and I said, let me get the infection under control, right? His infectious disease guy is a pleasure to work with, and we do. And guess what? He heals. He heals great. And matter of fact, so he comes to my office, and this is now, we're into, 2 years, 8 months. He's walking in a boot, but he's walking. So he's going to walk for a year in that boot before I let him take it out. And he drives up in a brand new Hellcat. It's an 800 horsepower car, okay? And he's got a boot on his foot that you hit the gas with. I thought it was a gift for me, by the way. I thought I did. I did. This is that Triumph you want to march around. I thought he bought me a car. It turned out he did not, type of deal. And this is him, very, very simple, doing well. Now, the thing is, we sent him for a brace, and they did a nice job. And again, I check everything. Well, they made the brace. The brace pushed on the screws that are up here in his tibia, and now he's broken that down, okay? So now I have to go back, and I have to take out the screws, lift the whole device that's internal, and reset the screws, right? Because of the brace. So the smallest thing, these guys are walking an edge, and none of them think they are, okay? They don't think they are. And that's that little minute thing, right? Another lesson learned for me, which happens every day. But here's the big thing. When you're sending these patients to get worked up, right, you make sure who you're sending them to. Don't just send them to the first guy who has an open door, because the fact that everybody has the same initials after their last name does not mean the same thing. And when I talk to family physicians, and they say to me, well, he's a vascular surgeon, he's a cardiac, whatever it is. If that leg comes back cut off, they assume that the right thing was done. And I will tell you from practice to practice, whether it be podiatry or any kind of cardiologist or vascular surgeon or any doctor for that matter, it doesn't matter who they are. You've got to send them to who they need. And I've gotten to especially practice. Now, I'm a surgeon by nature. I don't really do wounds. I like to figure out why the wound happened and kind of make that better. But I have patients who come to me as a tune-up to know who they should go to. It's almost become a subspecialty for me, and it's quite interesting. And because of it, I'm quite popular, right? I get taken out to dinner a lot of times. But the point is, what you have to do is you need to be in control, especially of this patient, because they're sick and they need our help. And the bottom line is this: 1/3 of patients who are seen with an ischemic wound die with that wound intact. 2 to 3 times a week, I see a patient who has a wound that's been standing there for 2 or 3 years. And they've actually become friendly with it. They kind of named it like a pet. They become very comfortable. And comfortable, the most dangerous word in the English language, right? Because once you get comfortable with something, you're not looking for any changes. And you know what? The doctor who's seeing this guy, doing everything I would do, except he didn't get a vascular workup. Now, the first thing you know about tissue loss is there's some kind of vascular disconnect, right? That's the first thing. I don't do it in my office. I send them to a vascular lab. Why? Because I'm good at what I do, and they're great at what they do. And you know the best part is, if this guy has a vascular problem, he's going to be in Dr. Khan's office long before I ever blink, right? And the other thing that I insist on is Dr. Khan takes my call, right? Because he wants my patients. I need to know my patient gets in immediately. I'm not calling him for fun. Oh, maybe I do. But the point is, because this is not acceptable, and one more day is not enough. So if we go on very simply, if you look at diabetes, every 7 seconds, someone dies from diabetes. And every 17 seconds, someone is diagnosed with it. And every 20 seconds, someone has an amputation in the United States. That's 4,320 legs and feet amputated every day. Every day. So the problem is, what you heard all day, there's not a standardized treatment because everybody reacts differently, right? You like olive oil, I guess you'd say EVOO. And you know, my Italian little ladies, they do use olive oil on their skin, right? They tell me it's the greatest thing, and maybe it is now. But we cannot standardize treatment because everybody reacts differently. This is not an algorithm, right? It is not. So if you look here, we started looking at why are our patients suffering? Well, they're saying lower extremity amputations, diabetes are going up. They're back on the rise, and why? And they were trying to find all these really incredible things with patients. So they were looking at the cost of insulin. They were looking at why they were taking smaller doses, why they were using a different type of insulin that was prescribed, why they weren't filling, why they weren't starting. And I looked at this. Turns out, in 1921, 3 Canadian scientists invented insulin. They then gave it to the University of Toronto for $1, or $3, I'm sorry, I'm off. Well, it's an American dollar. Canadian, $3, here $1. Anyway, they gave it to them, and they gave it to anybody who wanted to produce insulin as long as they were willing to produce it. And insulin has done beautiful things, except this. Prices tripled from 2002 to 2013, and you can see what's happened here. They're great things. So my patients are getting cheaper insulin or not taking it because they can't afford it. And you know, there's a very interesting thing about patients. They're a lot of times embarrassed to tell you they can't afford something, right? But I think we found the problem here. These are great medicines, and maybe we should just be paying for them because they're not taking them, and then we put them in the hospital. It'd be a lot cheaper to take care of them at the front end than the back end, right? It really would be. So, you know the old thing, square hole, round peg, whatever. First we make our habits, and then our habits make us. And these people, like I said, have gotten very comfortable. And again, we're trying to standardize the treatment plans, and you can't. You cannot do that. It doesn't work. It doesn't help. And so the bottom line is, patients lie to you. They're going to lie to you. It's like my dad asking me my grades, and I said they're good. They're fine, right? Patients lie to you because you're their parent, and they want to please you. And they go home and they eat the apple pie, and they have the ice cream, they do everything they shouldn't do, and their A1C they can't tell you. They can't tell you what drugs they're on. And I'm going to tell you right now, become the parent. I don't care if you don't like me in the moment, you're going to love me in the end. Because if that thing goes south, they're going to blame you. And if it goes the right way, north, they're going to love you. And I promise you that I know how this road ends. We all do. Every one of us knows how it ends. And I dismiss a lot of patients because when you come to my office, you become mine. You have to go see 12 different specialists, right? And now a sleep specialist, 13, right? Type of deal. Because that's what happens. You take over. I call every doctor who sees them. I call their wife or their husband, their kids. I call their grandparent. I don't care. I call their dentist. And I tell them what's going on. So he can't hide anymore, right? He can't hide this. And that's what you do, because that's how you win in this situation. The next thing is, we know 30 million people in the United States are now living with diabetes. Forget that. 90 million plus are living with pre-diabetes, and they're now on drugs for diabetes. They're no longer pre. They are full-blown diabetics, and they don't want to accept that. And that's part of the coddling, right? It's kind of like you don't want to tell anybody you have a disease, and you do. The thing about this is we need to do something because by 2050, 1 in 3 of us will be diabetic. If your child was born after the year of 2000, 1 in 3 chance of that child being diabetic. And again, those numbers are going to get worse. And 11% of the healthcare dollar 5 years ago was being spent on diabetes. That number has gone up, but I haven't seen the latest figures. Now, this little innocuous thing, again, that little wound here, I gave this talk in Cincinnati. A doctor who was not there heard about the doctor I was talking for, a cardiologist. His podiatrist sent him twice to 2 different vascular surgeons who refused to intervene. Now, this is the number one reason a patient loses a leg above the knee. Osteomyelitis of the heel, because, again, no direct flow to the heel. And so here's what happened. The doctor very simply took a look, and you can see where the arrow was pointing. The posterior tib disconnects. And if you look at the heel, there's very little thing. There's nothing going to that heel. That is a patient who won't heal. It's an open door to infection, and it will come, okay? And that wound's going to take 6 months to heal. And when you tell a patient it's taking 6 months, they blame you. They think you're doing something wrong. You're not. It just happens to be the location. Well, this doctor was able to intervene. And the first thing that the podiatrist said, are you willing to drive 30 miles to see Dr. Hearn? First thing they said. And that's critical, because a patient who says no is nothing you're going to do at that point. You're not going to make them better. They're not willing to help. They're not going to get better. And he did. And you can see, when you take a look here, you can see what happened when he reestablished the posterior tib. You can see the tributaries going to the heel. Now, he still took a long time to heal, but he did heal. So as we go on, ABIs are insulting to me. I'm a podiatrist. Why not do TBIs or TCPO2s or something else? Because by the time you have vascular disease diagnosed at the ankle level, it's been at the foot for 5-10 years. And we could have done something if and I guarantee you, Dr. Kahn will tell you, it's a lot easier for him to work on it when he still has viable vessels than him having to invent vessels. The one thing valuable about an ABI is we know as it decreases, your mortality rate goes up, right? And so why do we wait till the patient crashes before we're doing something about it? Because everything here is long-term. It's not the motorcycle accident that happened in the moment. It's long-term. They've been living with it for a long time. So here's the thing. Dr. Ali came up with this. In 2005, a study showed that only 50% or over 50% of the patients who had an amputation had no kind of vascular workup. Right? 2005, we're going to forgive it because atherectomy and all this other stuff was really new to the lower extremity at that point. But his latest study in 2012 took 20,000 patients who were Medicare patients, and they found out that less than 54% had no vascular workup before an amputation. That is malpractice. That is malpractice. I am sorry. I have to tell you, that is ridiculous. We're getting worse, not better, right? That's where we are. Because very, very simply, if you take a look at it, you know, we made fun today and we talked, the first lecture was the obesity paradox, right? And we talked about it. But here's the thing. I still think I'm 17 years old. For some reason, the pants I wore when I was 17 don't close anymore, but I still think I am. I still think I'm that quarterback. I still think women look at me, right? I believe this. So this woman goes, puts on her best outfit, and of course, she sits on the smallest chair she can find. Now, the rule of thumb is if your behind is bigger than what you're trying to sit on, don't sit on it. Right? The second rule is the stripe should be on her outfit, not on her chair. Now, the third thing is get a really big dog, right? All these things make you look better. But here's the thing. You see that dog? He's the only thing in that picture that knows he's in trouble. And the only reason he's still in that picture is she's got that leash tethered tight. Now, trust me, everyone in this room has felt that way with a patient, right? We all have that patient we're all tethered to, right? And they refuse to help themselves. They refuse. So 180,000 amputations are happening in the United States per year, and that number is going up. 20 to 25% lifetime of diabetic will lose some part of their foot or leg. And this is very sad because 30 days into it after an amputation with below knee, 8 to 12% will be dead in the first 30 days. And above knee amputation, 10 to 15%. Those numbers went up a year and a half ago. 18 to 24 month survival rate in a patient with an amputation, you can see it very simply, 40 to 50%. Extrapolate that over to 5 years, it's not good. This is when infectious disease calls me and goes, we need to cut off the leg, there's an infection. I said, why don't we just put a gun up to his head, right? Because they're not looking at the big picture. First of all, you take a patient's ability to move away, and two things happen. You take a patient who has an ejection fraction rate of 17%, and you're making a heart work harder because they can't push blood back up by a muscle pump because they're not going to walk again. These people very rarely walk, and we'll go through that in just a second. So amputations are not benign. They are not, right? Just because they left the hospital and they're not infected at that point, they're not benign. It turns out, one of my favorite slides is this is me in 2002, right? I had a contingent of little old Italian old ladies, and they're the matriarch of the family. I think they killed their husbands. But anyway, they're here, and they come in with the family, right? They come in, kiss the ring, the whole thing. Their kids come with them, their grandkids. And this one little old lady who I adored came in and said to me, Dr. Block, I need two things. I want to go home one more time and make meatballs. And she said, number two, don't let me die without my legs on. And I couldn't look her in the eye. I couldn't. I walked out of that room and I had my head in my hands and I was mad, and I was cussing, and I was swearing. I'm a doctor. I'm supposed to know all the answers. I'm never supposed to lose. They didn't teach me to lose in medical school. They teach you? No, they told us you can do anything, and I couldn't. Now, I realized something else. When she was trying to tell me by going home to make meatballs, she was in a nursing home. And I was shaving down those ulcers and keeping them clean and escalating the antibiotic as the infections kept coming. She wanted to go home because she wanted A, to die at home. And she was scared. And that's what she was trying to tell me in front of her whole family. I'm driving one day and all of a sudden, she doesn't want to make meatballs. She wants to go home and die, right? That was her thing. In 2002, atherectomy came on the scene. I got introduced to cardiologists like Dr. Khan, and all of a sudden my life changed because people who couldn't heal started to heal. You know what happens when you start healing patients? More come, right? That's what happens. More came because they thought I had the magic wand, and I didn't tell them I didn't, but that's what happens. And that's why I'm on this stage right now, because in 2002, my life changed. I started serving the patient. Stop patting myself on the back, and I realized if I got out and we got more patients in sooner to the right kind of people, we could work as a team, we got better. Because I was working independently for a long time. You know what happened? I had left 5 years ago, 5 years before that, private practice, went to a university, because I decided making a lot of money wasn't as important as saving the world. Well, it's not that way. It really isn't that way. So the bottom line is, here's the thing. Treatment for peripheral vascular disease in the 1800s, we cut your leg off. If we liked you, we got you drunk first, and if we didn't, we cut it off and you died of loss of blood or sepsis. Those are your two choices. Wasn't a really good outcome. But we've looked at 200 years. We've gotten much better, right? Instruments have gotten better. We've gotten better. They no longer call us barbers. But in 2019, we're cutting off more legs than we ever had. Now, the argument can stand we're sicker and we're living longer and we're living sicker, like I said. That may be what's happening. But the thing is, if we don't keep pushing forward, we are not going to get on top of this. And this is becoming an epidemic, right? It's a world epidemic. This is where we're going. So because we've always done it that way, it doesn't work. So we have to find other things to do, right? And now we go pedal access, or we go below the knee. We don't just go from the femoral, from the hip down. Because I marvel the society would pay a large sum of money to take someone's leg off, and yet nothing to save it. And that large sum is someone's life. It is someone you know. It is 6 degrees of separation. And we're still living that, right? We're getting worse, not better. And in 2006, BTK, because I kept saying, can't you go below the knee? Because they had one vessel runoff. And the problem is they had enough blood flow to support the ulcer, but not enough to heal it. And so in 2006, these wonderful companies, and why industry should be part of this, and thank you, industry, for being here, is because they came up with the instrumentation so Dr. Khan could go below the knee. Vessels get smaller, gets trickier, gets harder. And in 2006, my Dr. Amsterdam, my Khan, opened up the second vessel. And patients who I couldn't get to heal started to heal. And so what did I do? I asked for a third vessel, right? Because I'm the bad girlfriend. I want that third vessel. Give me 2, I want 3. Just the way it goes. And and I want to tell you something. Thank you, all of you who work in the labs, because I know how long these take. I know that when you're sitting there and you could do something in 30 seconds or 30 minutes, and you're in there 2 or 3 hours to get through these calcified and horrible vessels, and you do it. And I get a call from the cath lab, and Dr. Khan's laughing. He's so happy. And it's like a celebration. And it is a celebration of life, because at that point, I know this patient's going to heal, right? So the bottom line is would you rather, and the percutaneous, making a small nick in your groin, going up the contralateral side over the horn, drop it down, and put in a balloon or a stent or atherectomize it, or anything you need to do to get my patient to get blood flow to that foot, I'm good with, right? Because this is the problem I have. And I don't even have a problem with this anymore. But once you steal my saphenous vein and a patient's already sick, we talked about the patient whose heart's barely beating. And all of a sudden you take my saphenous, that patient now carries a gallon of water in that foot or in that leg. A gallon of water weighs 8.432 pounds. And all of a sudden the heaviest thing a patient lifts is their legs, right? Any of us. That's why diabetics are bell-shaped with skinny legs. And all of a sudden a patient's carrying 9 more pounds and they're walking, and they can't even breathe to walk back in the first place. And what do? They stop walking. What does that do? Their blood pressure goes up. Kidney failure. All that. Their eyes start getting worse. So there's ramifications. Now, I'll take any way you can get circulation down there, just so you know. I'm not proud anymore. I'm not. But this very simply leaves me the ability, if I do see it percutaneously, they can have a do-over, right? they can have it done again. And this is an organic process. It doesn't stop because they went through the first time. So surveillance is key here. And my patients, I took this from cancer. Every 3 months, they got to go back to the lab and they have to have looked at. And if their patency isn't there, they have to go back and see Dr. Khan. Just that simple. I need the flow. I'm not looking just to heal the wound. I'm looking for a patient to have a life, right? So it's real important that there's durability, because 20% of patients don't get an angiogram before an amputation. And in my town, Columbus, Ohio, which is a big city, biggest one in Ohio, I got in trouble for prescribing angiograms. I got called on the carpet for it. You're a podiatrist. Why are you calling angiograms? I said, because I'm the guy cutting off their legs. Any further questions? And you know what? They all backed down. It was pretty impressive, because I thought I was in a lot of trouble at that point. But nobody could give me an answer. I said, well, why can't I order an angiogram? I'm cutting off their legs. Only 50% had an ABI, and most of these patients have limb salvage options, right? That's what and here's the thing. You may not know how to treat it, but you should know how to recognize it. And all you have to do is pass that patient off. It's that simple. You may not know how to treat it. You get it to MoCon, you get it to one of these kind of doctors like this, they're going to know who to have it done. Because there's nothing better than a roadmap that tells you how to get there, right? And if you don't know it, you know somebody who does. And letting that patient sit there and die in front of you is not acceptable. It isn't. Because, again, amputation is not a treatment. It's a death sentence, okay? So 8.3% of the population of the United States is now diabetic, type 2, and 5% of the population of India, and almost 7% of the population, which I'm sure it is now, is type 2 diabetic in China. Now, here's the amazing part. Our children, 1 in 400, are beginning so obese at such an early age, they're developing non-cirrhotic liver tumors at such a level that the CDC tells us by the time these children hit 35 years of age, they're going to need 5 times the liver transplants they have today. In a sicker society, where are we going to get that from? Regenerative medicine? Now, we're talking today about the Mediterranean diet. It's really important. So where better to go than Italy to bring Michelangelo's David over here to live for a year? And this is what he looked like after a year on our diet, right? So this is basically what's going on, right? But it's what happens. It turns out, the Mediterranean diet doesn't taste good. You just feel good, all right? There's a big difference. And we're into taste, right? We like taste. But the bottom line, these are our children. We've biggie-sized our kids. And I think, I believe it was Dr. Lavie? He said something very interesting. He said, Taco Bell, McDonald's, all those Burger Kings, maybe they're responsible for the fact that our kids have gotten so large. And all we have to do is go out and arrest the purveyors of McDonald's and Burger King. I would like to add one thing that he wasn't saying, and that is, today, my mother stayed home with me. She didn't go to work till I went to school. We have more single-family homes than we've ever had. And moms work just as hard as dad now, right? So there's a big thing. It's not that McDonald's hasn't been around for a long time, or any of them, but we can't afford to let our kids live like that. We're exercising less. I have a policy. If I come in and my diabetic is playing Candy Crush, I go through the roof. Right? Because the fact they're playing Candy Crush makes them want candy. That's how I look at it, and it's true. Because all of a sudden I notice in their pocketbook, in their hand, they've got a handful of mints that some rep brought in and put in my bowl that are not sugar-free, that they're eating, and they got it from me. I'm killing my patient. It's an annuity, right? Not a good idea what I just did. So the bottom line is you've got to keep your hand on everything. So how do you treat this? Well, first you invent the technology, in this case atherectomy, to treat the pathology, right? And there's that pathology. But the most amazing part is you have to have meetings like this to change the psychology of us, the medical professionals, not the patient. The patient will follow you blindly. A patient who's in fear of losing something on their body, a leg, a foot, whatever, will follow you blindly. It's cancer treatment where they say there's no other treatment, there's one experimental thing they're doing, and they'll sign up not knowing what they're getting into. But that's how important it is. Here's the trick I do. I said, do me a favor, go home tonight and walk around on one leg. Use crutches, use a wheel, use a knee walker, I don't care. And then come back to me and tell me how that was. Because I want them to know what they're heading for. I need them invested, and it's simple. Now, you look what breast cancer did. They named a race after it, Pink Ribbon, and breast cancer fell from 17% mortality rate in 5 years to 10 years later to under 7%, or right around 7%, only because they told the world it existed. And that's exactly what we're doing with peripheral arterial disease, right? Exactly what we're doing. You just need to tell people it exists, right? You know, my patients come in, and my gift is when they have venous disease, as Patty was just talking about. Why? Because my patient will run out of that office to go to a consult to see the venous, right? For venous, for venous ulcers or for any kind of venous problems they're having. So varicose veins are a gift in me because I get both, the artery is the back end of a vein, or the vein is the back end of an artery, however you want to look at it, but one doesn't work without the other. It's the yin and the yang. And if it gets them there, I'm happy. Now, the other trick I do is I give them a pair of socks that I bought for $1. They're compression socks. They're cheap. And I said, and in my note, I said, patient wearing compression socks. So when they go, and that doctor said, you have to wear compression socks for 6 months, they've already had them. And it's documented by me. So my patient gets intervened on a lot quicker. Just a little tip. So here's the thing. We're getting bigger, right? We got diabesity now. Not to be funny, and you've heard me say this before, but I flew Southwest here, and I'm sitting in my seat. I'm hoping that no one sits next to me, and that guy gets on with the extender belt, and he's got the big 400-pound body with the stork legs, and he's walking sideways like this down the aisle, and he's looking at the seat next to me, and I put my head down on my hands, and I say, God, it's not very nice of me. If you let him sit somewhere else, I'll start going to church on Sunday. I do. I do. I mean, we all do it. You may not admit it. I mean, come on. When you're walking down the aisle and you see that I'm not sitting there. I actually recruit people. I pick out thin people to sit next to me on the plane. But the point is, what's very simply happening here is this is what we're doing. This is where we're going for the society. We're getting sicker, which isn't good. So if you take a look, less than half the patients will ever walk again after a below-knee amputation. 50% or only 25% will walk again if it's above the knee. 25% require nursing home care and full-time, and in the state of Ohio, that's $107,000 a year. One-third lose the remaining leg in 18 months. In the United States, amputation rate is increasing, and a diabetic is 28 times more likely to have an amputation if they're hospitalized, right? That's the problem we're having. So my biggest tool is not EMR, it's a phone call. I guarantee you if I call Dr. Khan, he's going to pay special attention. And if you call me, same thing. So I make sure I make the phone call. It's the best tool I have. They hear my voice and my concern, and they take care of the patient. So phone's still my favorite thing. So in 2006, below the knee becomes the call, right? They've got the instrumentation, now the skill set. I'm on my way to Kentucky to give this talk. I have the 11:30 to 12 slot. I start at 12:15. So they're hungry and they're angry. On the way there, I stopped at Burger King to get a quad stack, or I stopped to get a big iced tea, but they had something called a quad stack on the counter, which is Whopper cheese bacon, Whopper cheese bacon, Whopper cheese bacon, Whopper cheese bacon. 1,700 calories on a bun. It's good too, by the way. So he's not here. Levy's not here, right? The obesity guy's not. Anyway, I get to this meeting, and everybody's angry because I'm starting at lunchtime, and they're hungry and they're angry. We call it hangry, right? And I'm screaming BTK, below the knee. First time, we've just gone there. I'm so excited. They're hearing Burger King. And this brings up a good point. In podiatry, we have something called a bunion. It's called an HAV. If I say to a patient, you have HAV, they think they have a venereal disease, right? They're ready to go home and kill their husband. I'm like, whoa, it's a bunion. If you say SFO to me, I think you're flying me to San Francisco. You tell me CTO, chronic total occlusion, I think that's a car Pontiac built between 64 and 72. So when you talk, I call it cross species. When you're talking to me, you have to talk my language. If it's yours, you have to explain it to me. I'm not that smart. So you need to make sure when you're talking, you explain what you're telling me. Because at the end of this talk, at the end of this, what they understood is, Burger King can get you on the table, but a below knee, now pedally trained physician can get you off that table with your leg intact. So I'm at the football game, and this guy takes off his shirt. We've seen him at the pool. We know this guy, right? I'm sure they have him up in Redding. Come on. You guys are almost bears up here. I heard you had a little snow this year. Hibernation. I had forced hibernation, right? This guy takes off his shirt, and I stop watching the football game. And I start thinking what we could do with this guy. I'm thinking electrolysis, Nair, maybe shaving his back. I don't know. But why would he do this? And I completely forgot the football game's happening. Now, Candace, if you want, I have his number. So if you want, meet me afterwards. I'll give you this number. But the point is, now that we recognize it, we need to do something about it, and we can do something about it. Because in this next slide, watch the gentleman's right foot. Now, the interesting part about that is we're going to put him back together, right? The Joe Seisman thing. But the guy who comes in, we cut off his foot, it's worse. And the sad part is he didn't have a train wreck like this. It just happened. And we let it happen. And we watched it happen. And then all of a sudden we came running in at the end. And that's not okay. So my thought about the ABI is this. While it's not my favorite, if I get it, a copy goes out to every doctor because they need to hear this. Because if I tell you I caught a fish this big, you go, Block's a pretty good storyteller. I bet that fish was this big. But if I lay down next to that fish and take a picture, right, you pretty much got to believe, and I'm not good at Photoshop, that's a big fish, all right? And that's exactly what I do. By sending out that ABI, even if I don't do it, and I let the other doctors know, I let them know what a problem exists, right? So, very simple things. If you're looking for calcium, which is a big problem, it helps Dr. Khan if you send that patient. If that patient has an ABI of greater than 1.3, it's indicative of calcium. Critical limb ischemia is this calcium after it went higher, it blocked. So this is 75% blockage. At 90%, we went to critical limb ischemia or 0.4 or below. Why didn't we intervene here? Because the guidelines tell us not to. Patients not having pain, but they can't feel. Another story. Diabetes, if it's been there with or without neuropathy for 12 years, right? Another reason those patients have calcium. Calcium on forefoot x-ray. So when you see a patient and their vessel is calcified, that's the patient I go to bed thinking is doing really well because I can feel that pulse. How about if that blood can't get out of that vessel because that vessel's stone, right? If it's bone, what happens if they can't get out of it? Maybe that's what happened. You know about smoking. We won't talk about it. If their creatinine is greater than 1.7 or GFR of less than 60, these patients are calcium form. And he just needs to know because the equipment, the instruments he needs, he can have ready so he can save this patient's leg. So my favorite slide is Uncle Sal and Aunt Em. Uncle Sal is your grandfather. He's whoever he is. He's my neighbor walking down to the post box on his walker, cussing under his breath. And I can't figure why he's so pissed off with life. He's the guy I see sitting at the mall. And I figure he's sitting because he hates shopping as much as I do. And Aunt Em, every step she takes, he has to take 2 or 3. And he hurts, and he's out of breath, right? This is that guy. My partners will put a hip or knee in this guy at 90 years old. But at 86, where he is here, they won't. They won't send him for a vascular workup. Now, quality of life at 86 is no different than 56 or 40s. It doesn't matter. It's quality of life. And we have the ability to treat these people. So now that we know how to do this, how do I kickstart you to start diagnosing and sending them? It's really simple. I know you have to fill out a form, and I hate it too, but that's what we need to do. Because, this slide right here, you know this. Peripheral arterial disease, about 60% of them are dead in 5 years. It's just what it is. You add cardiovascular disease, which they're all in collusion. They're all in cahoots. Far outpaces cancer. Far outpaces cancer. If you take a look here, a friend of mine who's a cardiologist, Tom Davis, says this is cancer of the artery. And when I describe to a patient, they don't care about plaques. They're not going to see that. But if you say cancer of the artery, they understand, right? They do understand that. So if you take a look, only 31% of wounds heal in 20 weeks. So when I go and I look at a wound care center, and I don't go to one, 85% of amputations are preceded by a foot ulcer. 80% of hospital admissions, I told you, are from diabetics with a foot infection. Half the size in 4 weeks. If that wound is not half the size in 4 weeks, there is something wrong. And you need a nutritionist and you need an interventionalist, okay? Just so you know that. And again, when you start to look at calcium, Vanderbilt did this thing and they were trying to figure out why there's so many amputations. And they finally figured out if they have calcium, the chance of amputation goes off the charts. And they simply came up with calcium equals CLI equals amputation, associative math. And the Cleveland 66, Dan Clear at the Cleveland Clinic, amputated 6 legs at the pelvis, froze them all. They all had an angiogram at least 6 weeks before the amputation. And then one by one, they thawed them and tried to do cut downs. Well, first they tried to IVUS them. They tried to do an angiogram after they thawed them, and none of them could. And every leg they cut down on was full of calcium. And that leads to something very interesting. If you have a diabetic, right, and are claudican, so they could be diabetic, kidney problems, older than 65. The average claudican, if they're just normal, one of us, the chance of them going from claudication to CLI, or critical limb ischemia, in 1 year is 2 to 3%. That's what all the journals say. If you take the category of kidney problems, I say transplants as well. You take older, and you take diabetes. The chance of one of them going from critical ischemia from claudication in 1 year, 37%. Over 1/3 of them will have critical ischemia in 1 year. So what are we doing by sitting around? Nothing. So very, very simply, if you restored the flow first, because that's my first go-to. I don't care how many artificial tissues you use, or amniotic tissues, or hyperbaric oxygens, or injections of amazing things, and the right antibiotic. If you don't restore the flow, that patient is not going to get better, and we're going to throw good money after bad. So restoring the flow is critical. And when I see these wound care centers who tell me they have zero amputation because when it goes bad, they send them to the hospital to have the amputation, they don't have to count that. And I think that's going to change. At least I've asked Medicare to do that. So bottom line is this. This is pre and this is post. And you can see here, you can see healing, right? You can see the magic that can be done. Now, if we look here, getting down to the final slide, my favorite case, I talked about it 2 years ago. And if you saw me last week, I did the same thing. My favorite patient to talk about, I dislike this woman. Okay, I know you're not supposed to say that, but I dislike her. She's the meanest human being I've ever met in my life. And when she comes into my office, she greets my staff by going, "Oh, honey, are you pregnant or are you just fat?" So I'm already buying lunch for the office, okay? It's an expensive day at my house. And I literally see her chart, and I do this. I start walking back and forth about 3 or 4 times. I think she likes me, by the way. She lives at a retirement village, not a nursing home. Don't confuse them. She's just, I don't even know if she has teeth because I've never seen her smile. Not a joke. You can see as all as she's 83 years old, non-healing toe wound. She has died. This is 10 years ago. Tissue loss, gangrene. She has rest pain. She smokes 3 packs of cigarettes a day, admits to 2.5, drinks 2.5 to 3 highballs a day. I once asked her, why not 3 all the time? She says, sometimes I pass out. Okay, so I kind of like her a little. She has an ABI of 0.4. Which means critical ischemia, and she has a stent in a renal artery, okay? And you can't get them to quit these habits, you just can't. She comes in on this particular day, says, Dr. Block, can you save that toe? And I tell her, certainly, in a box, right? And she doesn't think I'm funny, right? So, yeah. So what I do is I send her out to my Dr. Khan. Dr. Amsterdam goes, and this is what I call the Salvador Dali of superficial femoral arteries. Somewhere up here it stops. Right about here it reconstitutes, and you can see the collateral circulation she has developed over time. So if you look at that picture, so this is what he did. He actually did atherectomy, and you can see the collateral circulation goes away, okay? And you can see that that vessel opens up nicely. Now, here's the best part. Every week she comes back. She's forgot Dr. Khan by now because I'm the guy treating her. I'm getting all the credit, and I accept it freely. Every day, every once a week, I carve back, I shave down. And if you look here, you can see how bad that foot is. You can see, if you're taking a look at the foot, she's not going to lose a toe, she's losing a leg, because you can see there's no circulation. Now look at her 60 days later. 60 days into it, I peel back, this little black helmet falls to the floor, and there's a little pink digit where there was a black helmet. And she smiles. And by the way, she had teeth. But here's the best part. She goes back to her retirement village, and she tells everyone that Dr. Block grew her a new toe. Okay? Guess what happens to my phones? Yeah, my phones start ringing off the hook. And people come in, and they, not for feet, they have headaches, and their shoulders hurt, and they have hip and knee pain. And they just want me to lay my hands on them because they think I can heal them. And I let them come because I need the office visit, you know? But they really believe that I have some kind of magic. It wasn't magic. It was cooperation, right? That's all it took. It took me knowing the right doctor to get her to, and that's all it really took. That's the magic we're looking at. So I will end with this slide. I took two articles from interventional cardiology, 2 from interventional radiology, 2 from vascular medicine. They all said the same thing. You open up 1 vessel below the knee, open up 2, that patient will start to establish a lifestyle and even ambulate, which is important because you remember, your feet, right, they pump blood, they help the heart, they work in some kind of great movement like that. But if you can open up 3, that patient can start a life again. They don't need to go to the doctor every day. Their wounds heal. They're doing pretty well. You got to keep them supervised. Because when I read an ABI to a patient, I don't go through the whole thing in the waveform. I go, when that thing is flat, your leg's dead. Okay, it's just that simple. I was sitting having dinner with 6 vascular surgeons from UCLA after we'd watched 5 live cases. And they said to me, Dr. Block, there's not one of those patients we would have intervened on. And I said, well, why not? They needed it. Nope, our number one reason for intervention is pain. And I said, well, that's interesting. My patients can't tell me they have pain. So do we not treat Helen Keller? Right? Is she fine because she can't see and she can't hear and she can't? Is that what we do now? Is that how we treat? They didn't realize that. We built a bridge that day. And it became this. What makes you medical professionals, whatever you're doing, is when you go beyond the book, right? And you start to practice. You take all the information you ever had and you use it to your benefit and you start to follow your gut and you start doing what's right for the patient. And this is where it came to this. We can no longer afford to be deaf to a patient who is mute, right? You want to practice medicine? Welcome to the arena, because that's what we do here, right? I don't want substandard. Don't come work with me if you're substandard. I do the same thing. I ask my nurses to be just as good. I try to be my best, and I ask the patient to step up as well, right? Because the hardest thing I've ever done is try to cure a patient who's not on the same page. It doesn't happen, right? It doesn't. So with that, I end, and I thank you for being here and your patience.